Everyone, my name is 𝗂𝗃𝗏 and I am a principal in the Climate and Health Thematic Leader Genesis Analytics. It is my pleasure to welcome you to today's webinar on HIV prevention and a change in climate. This is the last webinar of the year for SSLN, so I hope you have come all energized, ready to end 2025 with a bang. Before we get started, I would like to remind you of a little housekeeping. Please remember to write your name, organization, and country in the chat. We have interpretation services available in French and Portuguese. Just remember to please click the interpretation icon to choose your preferred language. Remember to put any questions that you have in the Q&A box, and we'll address at the relevant time as well. So next slide, please. All right. Thank you. So, according to the United Nations, climate change is the single biggest health threat facing humanity. And when it comes to climate-sensitive health threats, what usually comes to mind are diseases such as malaria, dengue fever, respiratory distress, malaria, diarrheal diseases, heat stroke, malnutrition, and stunting. And many of you may be asking yourselves, what has this got to do with HIV and its prevention? Well, research shows that extreme weather events and their after effects threaten access to and quality of critical HIV prevention and treatment services, antiretroviral therapy supply chains, and the social determinants that influence vulnerability to HIV. This impact is even more acute for adolescent girls, women, and children who are already at increased risk of morbidity, mortality, and economic losses in high climate risk settings due to their physiological, structural, and social behavioral vulnerabilities. So in today's webinar, our goal is to explore regional best practices for integrating climate adaptation into HIV prevention strategies, policies, funding, and implementation. Specifically, we want to understand pathways through which climate change is disrupting HIV transmission prevention and care, with a focus on vulnerable communities and health systems. We also want to learn from practical examples in the field about how communities and health systems are building resilience and adapting HIV services to climate-related challenges. We also want to identify concrete opportunities and actions to integrate climate adaptation into HIV prevention strategies, policies, and funding mechanisms. Next slide, please. Thank you. So here we are with the agenda. I am very proud to be doing the welcome address. And then we're going to have presentations from Frontline AIDS and UNAIDS, followed by a panel session on voices from the front lines. We will then go into a Q&A session, and then we'll have remarks from Global Fund, and then I'll come back again with next steps and closure. Next slide, please. So it's my pleasure to welcome the first presenter. Alison Wilson is a senior advisor for funding and partnerships from Frontline AIDS in the UK. Alison has experience in HIV/AIDS and community development and is passionate about the climate change health nexus. She coordinates Frontline AIDS Climate Task Force and holds an MSc in Global Public Health from Queen Mary, University of London, and a Master of Arts in Geography from the University of St. Andrews, Scotland. Welcome, Alison.
Thank you. I think we can go to the next slide, please. And the next slide. So I'll just start by introducing Frontline AIDS. So Frontline AIDS is one of the world's largest partnerships of civil society and community-based organizations working to end AIDS. Today, our global partnership works in more than 100 countries to support local, national, and global community action on HIV, health, and human rights. We're a global network for learning and sharing, and our partners bring practical experience implementing climate health programming and responding to climate change. Frontline AIDS began looking at HIV and climate change in 2022, and we've been focused mainly on understanding the evidence around the effects of climate change on HIV and on how our partners and the communities we work with are being impacted. What we found is the links between climate and HIV are often under-recognised in research and practice, but climate change could be devastating for the HIV epidemic globally. This led us to publish the evidence brief, which you can see on the screen just now. And within the evidence brief, we have our framework, which demonstrates the effects of the climate crisis on HIV. And we also have some case studies from community-based partners. I forgot to put my camera on. Let me just put it on now. Here we are. Sorry. The brief and the framework were informed by conversations with Frontline AIDS partners, funders, and many other individuals interested in the climate health intersection. We conducted an extensive literature review, and the framework paints a holistic view based on the evidence of the many ways climate change affects the communities most impacted by and people living with HIV. And before we jump into the framework, I wanted to start with some of the evidence. And on the slide, we have two statistics that came out of the literature review. In the first, you can see if current trends continue, we could be looking at between 11.6 and 16 million additional cases of HIV in sub-Saharan Africa by 2050, which would be an increase in HIV prevalence of between 1.4 and 2.1%. And in the second, you can see studies have demonstrated increased HIV prevalence rates linked to drought. So what the evidence shows is that while climate change doesn't directly influence the HIV virus itself, climate change can and does increase rates of HIV and negatively impacts the health and well-being of people living with HIV or people affected by HIV. Go to the next slide. So here we have Frontline AIDS climate health framework, and we're just going to have a look at this kind of layer by layer. So if we go to the next slide. So at the top, we have the consequences of climate change most relevant to HIV, as identified in the literature. And these include weather-related disasters, sea level rise, changes in precipitation and temperature, and air pollution. And it's important to note that these are highly location-specific and could look quite different in different geographies as the climate crisis and climate change impacts different geographies in different ways. Who goes to the next slide? So next, the evidence shows that we have these interconnected pathways that lead from the consequences of climate change at the top to the health and HIV-related outcomes at the bottom. The pathways are all interconnected and they're quite difficult to separate out, but taken together, they lead to reduced health and rights related to HIV. So the first pathway we have is increased human migration. And we're thinking there both about the displacement of large numbers of people all at once in the face of a major environmental or climate disaster, and also the slow, steady movement of people as temperatures increase, rainfall decreases, and crops fail. Migration can be significant and devastating, affecting livelihood support systems and communities. And in sub-Saharan Africa, it's estimated there will be 86 million climate migrants by 2050. A study in Lesotho found climate migration doubled a young person's odds of acquiring HIV. The second pathway is increased prevalence of other diseases, and that includes waterborne disease in the case of flooding, also vector-borne disease, where temperature increase due to climate change means the mosquito that carries malaria is expected to be able to survive in new locations, and that's projected to include the highlands of Ethiopia, Kenya, Zimbabwe, and South Africa. We also see increased zoonotic diseases, and studies in Malawi and Uganda have shown increased HIV viral loads in patients at time of malarial infection. Third, we have increased food insecurity, and that's both for subsistence farmers and for people purchasing food. As crops fail, food gets more expensive and more difficult to access. And this applies to plant and animal stocks and also fish. With increased water temperature, we see a negative impact on fish stock. And food insecurity has been linked to increased transactional sex, heightened risk of condomless sex, women's dyspareunin, poor ART uptake, adherence, and efficacy, poor immunological and virological responses, higher mortality, and earlier sexual debut. Next, we have increased economic stress. If you go back one. Thank you, sorry. We have increased economic stress that applies to agriculture, but also has a knock-on impact across all other sectors. The majority of people living in poverty depends on agriculture and natural resources for survival. And a systematic review looking at the impact of drought on ART adherence found economic and livelihood-related challenges had the strongest impact on non-adherence. We have increased conflict, terrorism, and eco-fascism. And what we're referring to there is a rise in nationalistic or white supremacist sentiment in response to climate change, which in turn causes people to close borders and not share resources. And very often it's marginalized communities, including LGBTQI+, and people living with HIV, who are blamed and targeted for harassment or violence. And finally, we have the erosion of the health infrastructure, which includes weather-related disasters affecting the physical infrastructure, destroying medical records, disrupting medicine or supply chains, and also health systems being stretched by the increased burden of disease. Next slide. And these pathways lead to the health and rights related to HIV. Climate change doesn't directly influence the HIV virus itself, but it results in changes in environmental and social systems that impact everything from how HIV infections are transmitted and contracted to how likely or unlikely people are to live well with HIV, and also the level of age-related deaths. On the left, we have the increased rates of HIV. And on the first slide, we saw that modelling from 2020, which indicated a potential additional 11.6 to 16 million cases of HIV by 2050 as a result of climate change. This is in part due to reduced access to prevention services, which could be due to the erosion of the health infrastructure, the displacement of large numbers of people in the face of a humanitarian crisis, people who don't have access to services. And it could also be individuals with increased economic instability who don't have the means to access services. And that includes everything from PrEP, HIV testing, treatment, HPV vaccines across the full kind of spectrum. In 2009, after flooding in Namibia, 87% of people living with HIV reported disruption to services, and 23% reported missing their medication. And the evidence also shows increased risk situations, which result from these climate-related pathways, and that includes gender-based violence, child marriage, and sex work, all of which are linked to increased rates of HIV. And we also see reduced health and well-being for people living with HIV, and this includes reduced access to ART and mental health services. It's important to note the effects of climate change, and these pathways are drivers of stress, which increases the need for mental health services. In environments with food insecurity and economic stress, we see reduced nutritional quality, which is important as it has an impact on the effectiveness and adherence to ARVs. And finally, we see increased morbidity or mortality from other diseases, and increased discrimination and abuse due to HIV status, gender identity and expression, or sexual orientation. We go to the next slide. And alongside this, we see two amplifiers which exacerbate this cause and effect relationship. The first is the social determinants of health, which are individual characteristics like sex, level of education, income, etc. There's significant overlap between communities who have increased vulnerability to climate change and those who face barriers accessing SRHR services and who are at increased risk of HIV. The social determinants of health compound and magnify outcomes related to both HIV and the climate crisis. So the populations who are most marginalised are also those most disproportionately impacted. And secondly, the capacity and resilience of the health system and government response is also important when it comes to climate consequences. For example, if health systems have in place adaptation measures to counter weather disruption, So thinking there about ways to transfer medical records or treatment regimens, backup power, water, or staffing plans. Then the same climate consequences can have vastly different outcomes. And the resilience of the health system supply chain is also critical, as well as the government's ability to provide education, temporary housing, and other support. To the next slide. If you just go back one. If you notice, our framework demonstrates only the impact of climate change on HIV and not the reverse. And this was a deliberate decision for a couple of reasons. Firstly, we didn't find specific evidence quantifying the extent to which HIV could fuel further climate change. We know, broadly speaking, the health sector contributes around 5% of global greenhouse gas emissions, but 65% of that comes from just a few countries. And we also know that the people who are most vulnerable to HIV and living with HIV are not significant contributors to climate change. So we focused the framework accordingly. There is some new research from UNITAID who are looking at the climate vulnerability and climate impact of key health products. So they've started to look at that, kind of quantifying the impact that HIV might have on climate change. And I can pop the link to those papers in the chat. Go to the next one. So since publishing the framework, we've started to think about what action is needed. The pressures on the HIV response from climate change are only going to grow more urgent with time. And to tackle these interconnected challenges, stakeholders across health, environment, and social sectors need to join forces and work on three key priorities: integrated financing, integrated programming, and strengthening community-led approaches. Next slide. So integrated financing between climate change and HIV is increasingly necessary because of the overlapping vulnerabilities that these two issues create, particularly in resource-limited settings or regions. Donors play a critical role in supporting integrated financing efforts that address both climate change and HIV by adopting strategies that recognise the interconnectedness of these challenges. And these strategies might include better coordinated funding and policies. Traditional funding models often isolate health and environmental issues, but an innovative integrated approach could mobilise resources to strengthen healthcare system resilience and also respond to climate HIV links in both immediate and long-term ways. We need strategic alliances between health organisations, climate action groups, governments, and funding bodies to address the unique vulnerabilities that climate change imposes on HIV prevention and care. And we need to encourage partnerships between climate change finance bodies and health sector funding mechanisms to create more comprehensive investment pools that support projects tackling both HIV and climate adaptation. Go to the next slide. National governments also need to recognise the links between climate change and HIV and address these through integrated policies and programmes. This integration could be promoted or achieved with the following activities. So better aligned policies between government ministries. Joint frameworks can ensure HIV programmes are resilient to climate-related disruptions, such as by integrating HIV services into emergency response planning. And united or unified policies can direct resources towards climate-smart healthcare solutions that serve HIV-affected communities, particularly in high-risk areas. Policies need to be able to provide flexible, climate-resilient care and preventative services that maintain continuity during environmental disruptions. And that includes supporting decentralised, community-led health systems that can deliver services in diverse and challenging conditions. We need HIV services to be integrated in broader disaster response plans, ensuring that patients have continued access to ARVs and healthcare support during and after natural disasters. And countries need to be supported to integrate HIV and community-led responses into their climate adaptation strategies, and in particular, the national adaptation plans. Next slide. And civil society and community networks need to be forceful advocates for the role of community-led responses across the response to both HIV and climate change. By leveraging grassroots connections, advocacy, and organisational capacities, CSOs can strengthen integrated community-led approaches with a focus on community-led health systems, which are essential for rapid response and service continuity during climate events. The strong community health systems created over decades of the HIV response need to be used as a template for similar efforts within the response to climate change, empowering communities, particularly those most affected, to drive solutions. And in the context of climate change, communities experiencing the worst impact should be empowered and included in local decision-making. Local knowledge and grassroots actions can amplify larger initiatives and foster resilience. We need to allow trained community organisations to carry out key activities, such as distribution of ARVs or monitoring patients' health during periods of climate disruption, to reduce the reliance on centralised health facilities. We need to foster and finance community-based peer support groups and networks that can provide resources, information, and emotional support in the face of disruptions, reinforcing adherence and resilience at the community level. And we need to ensure that civil society organisations and community-based organisations are involved in advocacy to secure integrated financing. These organisations often have unique insights into the needs of the affected communities and can lobby for more targeted funding. And I think I'll stop there. Thank you.
Thank you very much, Alison. It was very interesting walking from the science all the way to the advocacy piece. So thank you for your sharing your knowledge. Next up, we have Marietta Wilt from UNAIDS. So Marietta is a gender and SRHR specialist working at the intersection of HIV, GBV, and humanitarian response. With experience across UN agencies and grassroots movements on 3 continents, she advances gender transformative, community-led solutions for marginalized populations in crisis and development settings. So welcome, Marietta.
Thank you so much for having me, Ajoa, and it's a pleasure to go after Alison. I will do my very best to speak slowly, so please bear with me and remind me if I'm failing. So yeah, thank you for this lovely introduction and for trying so hard to say my name correctly. I am here today, and you can go to the next slide, to speak about a study that UNAIDS has done over the course of this year and last year, together with UNHCR and WFP. Our consultant, Anjali Rawat, supported this work very heavily, so we're grateful for her for endurance. It was quite a long piece of work to get this done, and it was recently published. So you'll see that there's 2 QR codes here on the slide. One has a link to the full report, which you can also find by Googling, the title with UNAIDS. I also gave a full presentation about this report recently, and it was recorded. So you can also listen to that recording if you're not tired yet of listening to me after today. So obviously, today we're going to focus on HIV prevention. And this report is not about HIV prevention, but rather about HIV and SRHR broadly and how they have been integrated into the last 2 El Niño responses. And we really try to take a multi-sectoral approach to not just look at the health sector, but also at nutrition, at protection, etc., etc. But I'll come to that later. So I wasn't sure what the audience of today is, so I want to say briefly what El Niño is in case this is a new term to you. So basically, this is a climate pattern which brings both high temperatures and below average rainfall to Southern Africa, roughly from November to April. So it significantly affects agriculture, it leads to water scarcity, food shortages, and disease outbreaks. So El Niño phases are not, obviously we predict them, but they are not super regular. So it's a little bit tricky. So they are known to happen irregularly between every 2 and 7 years, and they can last between 9 months to 2 years. So we are looking at the last 2 responses. So the first one being in 2015, 2016, and the second one being in 2023, 2024. I'm not going to give you all the details on the climate part of it, but basically keep in mind the first one, while it was climatically stronger, the second one actually affected double as many people. So the first one was about 32 million people, the second one 61. because the second one affected more countries and it actually compounded with other crises like cholera outbreaks, conflicts, etc. So it had a more widespread impact. So you see it's already a little bit complex. You can't, and I think we're learning very nicely from what Alison just presented. So you can't just go straight from climate to HIV. It is a very multi-sectoral. There's lots of bidirectional connections. Next slide, please. So we did this study in 6 countries, being Botswana, Lesotho, Namibia, Malawi, Zambia, and Zimbabwe. We chose these 6 countries because all of them declared a state of emergency due to the El Nino-linked droughts. So it's easier than, the system kicks in and it's easier to understand, is this actually a response to El Nino or is this a response to a broader issue? So normally now I would speak about why we took this focus on HIV, SRHR, and El Nino, but I think Alison has actually covered this. But basically, we wanted to look at the key drivers, and I'm going to make it really quick. Social disruption and breakdown of community support, gender-based violence, of course, economic instability through food insecurity and limited supplies, and overall disrupted access to HIV services, which, yeah, I'm not going to go into detail on that one. So we already looked at before the study, we looked at the MISP assessment, which is the minimum initial service package on SRHR in crisis situations. And what we looked when they did an assessment was that that in ESSA, 24% of HIV prevention and treatment services are inadequately available at the onset of emergencies. So this is about emergencies overall. So we wanted to take a closer look what is happening in the emergency situation. So you need to keep in mind that HIV services are not recognized at life-saving interventions in the humanitarian architecture, which really means there's a massive risk to continue services in crisis. So again, not prevention specific, but you can't separate these matters. So yeah, what I want to show today really is we need to recognize HIV services, especially the prevention part, to be considered essential, because otherwise those populations, and that was something we saw before and that Alison pointed out well, especially those most vulnerable in the crisis setting will be most vulnerable to HIV transmission as well. For example, let it be through emerging coping strategies such as transactional sex or stigma, discrimination, barriers to care. Next slide, please. So let's start with something positive. So I want to start briefly with what has improved around HIV prevention. Again, it's a little bit tricky to fully separate from HIV services overall. But yeah, so what worked well is that preparedness and coordination, kind of the key issues, have improved a little bit. So between the 2 El Niños, there was a SADC preparedness plan drawn up for the second one. The FEFSnet, Famine Early Warning Systems Network, issued bulletins focusing on El Nino risks for the 2023 and 2024 period and beyond, which really demonstrated an improved approach to risk communication and early warning systems. Largely, this was facilitated through RIASCO, which is the Regional Interagency Task Team for Southern Africa, led by OCHA. So another thing that worked well was that there were a couple of innovative models, not just on prevention, but overall on HIV services that were used. So a very positive example that we looked into more deeply was that in Zimbabwe, there were HIV outreaches conducted in communities, which included providing supplies for viral load testing. And there was coordination across the different humanitarian sectors with district development coordinators to identify households that were vulnerable to food insecurity and included people living with HIV. So these 2 factors were overlaid and people living with HIV identified, and they received livelihood support, food supplements, etc. And it was really community actors in our research that described that having a better reach than before to identify people living with HIV and giving them the additional services and support they needed. Of course, there were lots of learnings. For example, that early warning systems only work when they are specific enough, when they actually turn into early action. So just having the warning is not good enough if it doesn't reach those at the time that needed. So for example, translating into local languages would be another important part. And yes, I do want to say, while the decentralization and the anticipatory planning really worked and improved prevention continuity, it was not on par with the needs that the actual situation would have needed. So now let me talk about some gaps. So yeah, I just mentioned that the early warning system didn't necessarily reach the most remote or high-risk communities. The same goes for the engagement of youth and key populations. I'm really happy that we have panelists falling under these categories today that can speak more deeply on this. HIV was not integrated systematically across sectors. Guidance was lacking, and you know how it often goes. It really depends on the individual that sits in a position if HIV was considered or not. Stockouts of all kinds of commodities persisted, and especially with the first El Nino, there was a massive gap on GBV, but I'll talk about this a little bit more if I'm not running out of time. And yeah, all these gaps that I just listed are so linked to prevention. So again, not separated by itself, but you can think about the steps that connect them based on Allison's presentation. So now I want to zoom in very quickly on 3 specific issues that I think are really worth highlighting because it gives us a lot of learning. So first of all, community systems are key. So working with communities is the most efficient, effective way. It's the best infrastructure we can rely on and to provide. May I ask for the next slide? Sorry. No, and again, so this one. And yes, this is where we are. Thank you. Sorry for that. So yeah, community systems are key infrastructure and most effective. So you know, UNAIDS is very focused on community-led responses, on community-led monitoring. I do have to say it was really difficult to find information on community-led work. So as much as this is something we would have liked to focus on, this is more about community-led, community-based in a broader definition. So there was an example about an effective community-based initiative, which included having community support volunteers who were themselves people living with HIV, who checked on each 10 other people living with HIV who were on AIT to ensure that they continue to be on treatment, and they even shared the medication when there were stockouts and it was needed. As much as this is a sad situation, it did help bridge shortages. We had various participants representing people living with HIV from Malawi who described the use of WhatsApp groups to reach communities for fundraising, for donating food, for supplies. Yeah, there was even accountability through posting receipts and showing the delivery of donated items. So really like community-led efforts. Yeah, and I think this shows that that in the future, the focus we would call for is around more meaningful community participation in all the stages of emergency response. So while the leadership is greatly appreciated, it needs to be embedded in the actual response. And another recommendation that we had is the establishment of regional community engagement frameworks and platforms across the board. Next slide, please. I'll briefly speak about HIV, GBV prevention and response, which is clearly linked to HIV because, as Allison mentioned, GBV is a crucial link to as a crucial reason for HIV transmission. So overall, there was a strong improvement between the 2 responses. The 2023-2024 response, there were many more organizations focusing on GBV, also civil society organizations, also governments largely in many of the countries interviewed. And I wanted to share one interesting example. In Zambia, there was a very successful approach to addressing GBV, which involved decentralized services. So community health workers who had been trained as GBV monitors effectively identified at-risk girls and women and empowered them through a variety of local interventions and also connected them with food security committees. And these committees were rooted in communities and really understood the actual power dynamics on the ground so that they were able to intervene and both prevent GBV as well as respond to sensitively. And so, yeah, there were massive gaps around referral pathways. Overall, especially survivor services were underfunded. But a big takeaway for our prevention work here is that they're directly linked and that they need to be embedded across all sectors. And specific funding for GBV services are crucial in order to make sure they don't get forgotten and fall through the cracks. The last example is around nutrition and HIV. So there was a very well documented project by PEPFAR and WFP focusing on the South, I think especially Lesotho and Eswatini, where nutrition and HIV were linked through government structures and other partnerships. They managed to provide equitable and HIV-sensitive programming targeting malnutrition specifically of people living with HIV. However, there were lots of challenges with this work, and they remain. So often it is difficult to align, for example, the delivery scheduled of ARTs with food distribution. So, for example, and we had other issues. Again, I think we're on the GBV slide. I'm not sure. And another issue, for example, is that when food assistance is integrated into healthcare, it often is an issue about storage. It's an issue about overload of healthcare workers. So while there were very interesting examples that we saw, a lot remains to be done to make them the most effective and efficient. And yeah, again, I think we're still on the GBV slide. Lastly, yeah, just as a takeaway, nutrition is integral to both make sure that people can stay on ARTs, but it's also a massive part of prevention, both for people to stay on PrEP and to reduce the risk of transactional sex. Next slide, please. Which is my last. So I'm not going to go in detail here. I think a lot of this I've covered. Yeah, the HIV prevention has to be anticipatory. It has to be community-led, multi-sectoral, and climate resilient. Prevention has to be based on stable food systems, GBV services, and innovative delivery models adjusted to the specific situation. And I figured I didn't have enough time, so I'm only highlighting this here through shared data system. A big issue, and there was the attempt to fix this between the two El Niño responses, but a big issue is that there's a lack of timely data of capacity for research to provide data at local level, of real-time monitoring systems. So this is really a massive gap that I think many actors have to be involved in to fix. Yeah, for the path forward, we hope, and the webinar is part of it, of course, that there's political will across all phases of emergencies to not forget the integration of HIV, to work with communities, especially focusing on community-led work, which is underrepresented. And lastly, and this is a big issue that is being thrown around in many ways, we need to figure out the best ways of integrating HIV. Standalone services are not an option anymore, but integration cannot mean watering down. So how can this be done in the most effective way possible, and not just in the health sector? So with this, I'm closing. I do have a lot of recommendations and lessons learned to share. So I would like to invite you to take a look at the actual report where this is both split into HIV, SRHR specific work and cross-sector system-wide approaches. Thank you so much, everybody, and have a good rest of the webinar.
Thank you very much, Marietta. I think you painted a very vivid picture of the realities on the ground. And it was also quite balanced because whilst there are challenges and those challenges are definitely real, I think you did a really good job in identifying the opportunities as well. And I think actually your presentation is a very good segue into our panel discussion. We have three distinguished panelists with us today. We have Dr. Pasquin Ogunsanya from Alive Medical Services. We have Julio Mutemba from Regional Psychosocial Support Initiative, and we have 𝗪𝗟𝗻 from 𝗲+ Malawi. So I'm going to first speak to Dr. Pasquin. So just before she starts, let me just tell you a little bit about her. So Dr. Pasquin is a public health specialist with vast experience in comprehensive HIV/AIDS care. She advocates for inclusive HIV/AIDS SRHR services for all, especially the marginalized. She is the executive director of Alive Medical Services, a nonprofit organization in Uganda, which was established in 2007 to provide and model comprehensive HIV services and other health needs for its clientele using a holistic approach. To date, Alive Medical Services has served over 2 million people. Welcome, Dr. Pasquin. Over to you.
Thank you very much, Marietta. Hello, everyone. I'm delighted to be part of this meeting, talking about climate change and how it affects HIV and AIDS. So let me tell you briefly about Alive Medical Services. Marietta did well to already mention some things, so that has helped save my time. So as Marietta has said, we are an NGO based in Uganda, and we were established in 2007. We provide free comprehensive HIV and AIDS and sexual reproductive health and rights services. We integrate it with non-communicable diseases like mental health, and we also do economic empowerment and many other health services. So annually, we serve over 218,000 very vulnerable and marginalized clients. And this includes children, youth, adolescent girls and young women, orphans, men and women, families, and key populations nationally. We work in 25 districts. We support 50 government health facilities in providing HIV prevention services to adolescents and key populations and high-risk populations. We've been a partner of Frontline AIDS since 2018, implementing several projects in Uganda. Our clinic is a single high-volume ART clinic with a replicable model, and we deliver high-quality medical services. In the last 18 years, we've tested over 321,000 people for HIV and served over 18,000 people living with HIV, 99% linked to care. We have been providing both inpatient and outpatient services. Our services are free of charge, and we provide prevention services like PrEP, PEP, condom, lubricants, social, behavioral change, communication, HIV counseling and testing, HIV treatment, including management of all opportunistic infections, advanced disease screening and management, TB screening and management, cervical screening and management, nutrition assessment and management, STI screening and management, screening for non-communicable diseases like I already mentioned, and we provide services, like I said, to all our clients. And I'm confident that AMS is doing a great work in health in Uganda, especially in HIV and AIDS and SRH for the most vulnerable and marginalized communities, evidenced by over 40 national and international awards received in the 18 years, including one presided over by President Nelson Mandela in 2007, one presided over by President Bill Clinton in 2015, and in 2023, we received the prestigious Presidential Award by His Excellency President Yoweri Kaguta Museveni. So as a partner of Frontline AIDS, we provide community-based, client-centered, and peer-led free comprehensive health services. I don't know if I still have time, but over to you, 𝗂𝗃𝗏. Thank you.
Thank you very much, Dr. Pasquin, for that overview of Alive Medical Services, and congratulations on all your accolades. Next, I'm going to introduce Julio Mutemba. Mutemba. Julio is the Country Director for Regional Psychosocial Support Initiative, which is also known as 𝗊𝗄𝗃 in Mozambique. They empower state and non-state actors to promote and contribute to the well-being of children, adolescents, young people, families, and communities using the mental health and psychosocial support approach as a tool. Julio holds a degree in sociology and a master's in cooperation for development. Welcome, Julio.
Okay, thank you. It's a pleasure for me to participate in this webinar. And the 𝗊𝗄𝗃 it's an organization present in 13 countries in Southern and Eastern Africa. Our focus, as it has been said, is improving service through mental health and psychosocial support. So in the current strategy, which actually is coming to an end, we have now developed a new strategy, but we have not yet launched it. But in the past 5 years, where our work was focusing on health and the sexual, reproductive, and the rights, with continued deep focus on mental health, HIV, prevention, testing, treatment, and care. And I think it was under this strategic outcome where we are also working with the Frontline AIDS, implementing a peer support model for adolescents living with HIV called the 𝗿𝗵𝗵𝗆 program, which now is coming to the second phase of its end next year, after 6 years of implementation. We also working on the protection, sustainable livelihoods, where we seek to promote the role of psychosocial support in integrating national and the community system for prevention and response to gender-based violence. We have support from partners like 𝗪𝗔𝗔. We also have support from the Hilton Foundation, where we focus on another pillar of our strategic plan, which is education, early childhood development. And one of the most important is disaster risk reduction in the humanitarian response. We've been responding to a number of climate issues or climate disaster, like the cyclone Idai and the Fred, which affected a great part of our country and other countries in neighboring countries around, like Zimbabwe and Malawi. We also provide the response. Last year, there was a massive flood in Maputo, which was caused by heavy rain in Swaziland, Africa, but also in Mozambique itself. And we are also responding to the victim of the armed conflict in the province of Cabo Delgado in the north. So I think these are some of the areas that we focus. We build the system strengthening and working in partnership with government, with support of UNICEF and other partners in the country. And thank you.
Thank you very much, Julio, for your presentation about 𝗪𝗃𝗃. Next, I'm going to introduce Ismail Piri. So Ismail is a dedicated youth advocate and national coordinator at 𝗲𝗄𝗆 Malawi, with a background in development studies and HIV management. He holds significant leadership roles across national and global platforms, including serving on the Malawi Global Fund CCM, the National PLHIV Committee, and the 𝗵𝗵 Healthcare's Adolescent Key Population Board. Through these positions, he remains committed to amplifying youth voices and driving inclusive, rights-based policy changes in HIV and SRHR. Welcome, Ismail.
Thank you, 𝗂𝗃𝗏. Good afternoon and good morning, depending from wherever you are actually joining this webinar from. As Jo has already said, my name is 𝗊𝗪𝗂𝗃, and I work with the National Association for Young People Living with HIV in Malawi. So just a brief about 𝗨 Malawi. This is an organization that was established in 2014, and we've been in existence for 11 good years. And we have the mandate under the National AIDS Commission and a global fund under MANASO to serve young people living with HIV by bridging them to healthy services and, of course, the social services, because young people actually reside in the communities and they have life to achieve their dreams and more. So on your screen, we have the slide of the project which we are actually implementing in Mangochi and Mulanje district called Together for SRH. So Together for SRH is a joint UN program that is supported by UNAIDS, 𝗀𝗵𝗃, UNICEF, and WHO to ensure that all people in the Eastern and Southern Africa region are empowered and supported to exercise their sexual and reproductive health and rights and access quality people-centered integrated SRH services to enjoy a healthy and productive life. The overall goal is to make sure that we fast track the attainment of SRH and health-related services and targets of Sustainable Development Goal number 3, which is good health and well-being for all, and number 5 about gender equality. So this is actually a phase 2 implementation, which is being implemented in the year 2025, which we're just coming to an end, and 2026 to December, with a national projected title of addressing broader determinant of maternal health, evidence on gender norms and attitude to enhance women empowerment and SRH decision-making in Mulanje and Mangochi district. Thank you.
Thank you very much, Ishmael, for that overview of your program. And now we're going to have a panel discussion. So I would like to first, my first question goes to Dr. Pasquin. Dr. Pasquin, how is climate change impacting the communities you work with and your work overall, particularly when it comes to HIV prevention?
Thank you, Joa. That's a very good question. Yes, climate change actually affects our community and the work we do in HIV and AIDS. So let me give an example how these weather disasters can affect our services. In the beginning of 2022, we experienced a prolonged drought. Then around July 2022, heavy rain fell on much of Uganda, causing flooding and the destruction of crops and infrastructure. And of course, in turn, there were some landslides. Actually, last year we had a landslide in Kampala, causing flooding. And these landslides, of course, caused loss of life, loss of homes, loss of property, and loss of income. Now, these weather-related disasters, the floods, the dry seasons, cause people to migrate to towns and cities. For example, we have an area called Karamoja, one of our driest and most poor regions. So people migrated from this region to the city, to Kampala, in search of food, in search of shelter. As migrants to the city, these communities don't have the social networks or economic opportunities they had at home. And they often resort to sleeping outside without access to clean water, food, or health care. And many times sleeping outside, they're bitten by mosquitoes. So this economic stress leads some of these climate migrants to engage in transactional or commercial sex, where it is difficult for them to negotiate condom use to prevent HIV or STI. So unsafe sleeping conditions leave them at increased risk of, like I already said, malaria, poor water leading to waterborne diseases, reducing the overall health and immunity. And also in these spaces, when these people have migrated as a result of climate difficulties, there is conflict because the infrastructure in the cities is already stretched and unable to cope with the arrival of new people. Certain groups, especially such as women and girls, ethnic minorities, and the LGBT communities are particularly at risk of HIV stigma. HIV, but because of stigma and discrimination, they often fear prosecution as well. So they can't even report if they're, under risks. So this is how it affects us. And then, of course, we know that in our country, healthcare is heavily dependent on people paying for their medical bills. So this leads to really, and already, the people who have migrated, they don't have the money they need for healthcare. So this actually increased their risk of infection in different ways because they are now focusing on survival, food that they can eat, and they cannot afford healthcare. They will not negotiate maybe safe condom use, and they will have unprotected sex. So this actually still exposed them to risk of HIV. And during these weather-related disasters, of course, like I mentioned, access to services, they are not able to. So things like PrEP, they will not. Even those who are already on ARVs, at that time, they are thinking of food to eat, where to sleep, than taking their medication. Back to you, Adjoa.
Thank you very much, Dr. Pasquin. I think that is a very sobering reality. So thanks for sharing that. My next question is for Julio. So Julio, what I want to know from you is what gaps have you seen in terms of HIV or SRHR service delivery in Mozambique during climate emergencies?
Yes, thank you for the questions. I think there are a quite good number of gaps that can be mentioned, but I just wanted to highlight one of the most critical. And I think what we've seen during the emergencies is that there is no prioritization of HIV service in the emergency response mechanism. The main focus is mostly given to the most obvious needs like food, shelter, sanitation, which it's common everywhere. But HIV is often treated as a secondary or even sometimes completely forgotten as part of the response needs that need to be taken into consideration. We've also witnessed disruption of drugs stocks or lack of prioritization of distribution of drug supplies, which lead the beneficiaries to be non-adherent, and also increase the risk of HIV resistance because of that interruption of assessing treatment for most of the people affected by HIV. We've also seen that in some circumstances, or in most circumstances, there is no creation of adequate conditions or space where people can continue accessing medication without facing possible stigma. So most of the time, people, they also fear stigma, exposure. So if the services are not provided in an adequate place, or which provides some kind of a privacy, so people, they become reluctant to go for the service. I think those are some of the key. There are circumstances where, because during the emergency, some of the people, they lose quite everything, even documentations like cards, which facilitates them to access health service. So sometimes when they are displaced to the new areas, Also, the system does not facilitate them to be enrolled in the new health facilities in those displaced areas. So I think those are some of the gaps that we've observed. But the most critical one is that HIV is not actually treated as a priority in terms of responding to emergencies. Is most of the time forgotten by the or the key stakeholders that respond to emergencies. Thank you.
Thank you very much for that very comprehensive response. Thank you very much, Julio. Next, I would like to talk to Ishmael and ask, as a youth-led organization, what challenges have you experienced as a result of climate change? And how is that impacting your work in young people, specifically in Malawi?
Thank you so much, Ajwa. I would like to first bring to your attention on some of the devastating moments which we actually experienced as a country. 3 years ago, we actually experienced Cyclone Freddy, which actually affected the lives of young people in the communities as we experienced the mud and mountain rock slides that actually killed a lot of people and displaced a lot of communities in Malawi. And this year alone, we've just started the rain season, but we've been experiencing the thunderstorms that have already claimed the lives of about 14 people in Malawi. Yesterday alone, we've heard reports in 3 districts where 7 people have been killed with thunders, and it's actually devastating to see how just the start of rainy season, but already we're experiencing some of the challenging factors and consequences which already affect access to health services and also has already changed the narrative in as far as HIV response is concerned. So as an organization, a youth-led organization, during the crisis, some of the challenges which we actually experience is infrastructure challenges, where when the rains actually comes and the climate actually changes, we'll experience, for example, the bridges being washed away, the houses of young people, which we actually target as an organization, being washed away. And this actually affects the work which we do, because we can't actually connect and link with young people anymore, because now being much focused on humanitarian services to give to these young people. And as a youth-led organization, we don't have much funding that we can reach out to young people with all these services, because one, we already have our focus, which is actually HIV, SRH, and other youth-related services, in which if we talk about humanitarian services, is actually something that is huge, that is not in our budget lines, and of course within our funding mandate. So you could see that even for us as an organization to reach to our target has been really challenging. And as for Together for SRH, as one of the projects which we're actually implementing, we have already experienced that this year. In THOA, Mangochi, 2 bridges has already been washed away. And you could see that as young people, to access the health services, they actually have to cross to the next locations to access a health facility. So if these are bridges that are actually connecting and linking young people through one community to the other, it means access to services has already been disrupted, access to information has already been disrupted, and our work as youth-led organization has already been challenged. So these are some of the challenges that we actually face as organization to complement the government through the work which we do to young people living with HIV on SRH services in Malawi. And of course, I also mentioned something around access to information, which we actually provide to our young people on HIV, SRH, and other related services. So during climate change, or I should say, especially in rainy season, one of the challenges which we actually face is because we can't travel to the communities. And the only platforms which we actually provide the information to our young people to make sure that they continue to access the services, they're actually blocked because one, it has to be physical through sensitization, mobilization, and community work. And you can actually agree with me that we are in digital era where young people no longer access information through televisions or radios. So you can actually see that even networks are disrupted because of the rains, the heavy rains which you actually receive, the storms which you actually receive. And for us to share that information to our young people automatically becomes challenging. So these are some of the challenges which we actually face as youth-led organization, and how can climate change actually impact our work as young people, especially in Malawi. You could see that already I've talked about the infrastructure challenges, where when the bridges have been washed away, the healthy facilities have been washed away, access to healthy services is actually difficult for young people to access. Access to information is difficult for young people to access. And you can also see that impact on livelihood among young people is also challenged because climate change actually affects agriculture, the backbone of Malawi's economy, leading to food insecurity and poverty, where actually more young people and the young people which we actually target as 𝗲+ Malawi are also into those activities which are actually disrupted and challenged. Thank you.
Thank you, Ishmael. And I think what stands out to me is the fact that this is not just, a community, organization, NGO health issue. It looks like there needs to be a lot of multi-sectoral response, because all the things you're talking about include like roads and infrastructure, like you said, agriculture, so on and so forth. So there are so many players that need to be part of the solutioning, because one sector cannot do it alone. So thank you very much for sharing that. Before we go into the next round of questions, I really do want to just remind the audience that they should use the Q&A box to ask any questions that for the panelists as I go along, because obviously you may have some really good ones that we may not have thought about. So please put in the questions, and then after we have the second round of Q&A, we will actually go through a formal question and answer section where we will go through your questions and talk through them. So please go ahead and use it. All right. So back to the panel. I want to go back to Dr. Pasquin. I want to ask you, how have you adapted HIV services to climate-related challenges? And what challenges have you faced doing this, and what works for you? Dr. Pasquin, you're on mute.
Can you hear me now? Yes, thank you very much, 𝗀𝗃, for that question. Of course, we know that these climate-related challenges, they decrease health and well-being for people living with HIV. Like the floods reduce access to mental health, economic opportunities, food, transport, shelter, medicine for people living with HIV, and also key populations. So we, like Ishmael said, and also Julio mentioned, that when these climate changes take place, then reaching the people that need services becomes difficult. So what we did was to mark where these people live, because as we register them for services, we know where they live. So we have had to support them in various ways. And of course, the challenge, you've asked what challenges have we had in reaching out to them. One of the main challenges we've seen is that when there's disaster, focus moves away from HIV. Actually, some of the resources that was meant for HIV is diverted to take care of that disaster or the landslide. So the HIV itself, the program usually resources get diverted from that. So we responded by supporting the people living with HIV and the marginalized persons that have been affected by climate change. In that year, when we had that challenge, we had a partner that supported us to give cash transfers to these people affected. And we were able to, for 8 months, we were able to support the most marginalized persons, 2,500 of them living with HIV, with the worst impacts, drought, there was landslide, there was flood. So we supported them with a cash transfer of $30 every month for 8 months to help them buy some nutritional food necessary for them to ensure they adhere to their ARVs and their varicella and other essential needs. Some even used it for transport. Some used it to help them boost their small businesses, to enable them to be economically stronger. They were able to eat, continue taking their ARVs. And we also distributed insecticide nets, mosquito nets, to prevent them from getting malaria. Then one of the things we do is also community outreaches. We know where our clients stay, so we organize targeted community outreaches. And when we do this outreach, it is a comprehensive outreach where we're going to talk about HIV prevention, we're going to test for HIV, and if we assess and see that maybe a key population is at a high risk, we already start them immediately on PrEP. And then we also give them, IEC materials to help them, and we, talk to them about prevention. And those who are HIV positive in the community, we already start them on treatment. And then in the community also, we do other tests. And we have also been doing delivery of all these supplies, prevention supplies, treatment supplies, to deliver them in the community. So we've been using couriers, but we've also been using people who can go there, any means that can deliver these supplies to them. And we've been using a lot of peers to, attaching a peer to a particular community to try and help this community. So that's how, but of course, the challenge, as my fellow panelists have mentioned, the challenge of roads being washed away, being blocked, and then sometimes you don't know where the people have gone to because people are scared or it takes them unaware. So people just look for where else they can go and have shelter and be alive. And then the other challenge is that they are sleeping in the streets, they are mobile, so it can be difficult to find them. And also because they are looking for food to eat, they are looking for where to sleep. So the challenge is also finding them, except if they come. And then many of them will need food supplies, many of them will need transport for them to be able to come for care. And of course, the main challenge is resources. We will want to do much, but the resources are very limited. Thank you.
Thank you very much, Dr. Pasquin. And I do love the integrated approach you talked about. So not just HIV treatment, you've done prevention, malaria prevention. I mean, that's I think a very good case study in itself. Next, I would like to just chat to Julio. So 𝗀𝗃𝐶's mission is to provide mental health and psychosocial support to children and young people affected by HIV/AIDS. How do you integrate mental health or psychosocial support in situations of humanitarian or climate emergencies? And why is this important?
Okay, thank you. I think the way as we integrate psychosocial support, I think it's also back to our strategy since the inception of 𝗀𝗃𝐶. Because, for example, in Mozambique, since 2010, we've been involved in the system strengthening, as I said, with the main focus on healthy, social, and education, the community system. So we've been helping them to enhance the capacity of the staff, like social workers, health workers in mental health, which allows the organization or an organization that is working on the field to respond to emergencies to quickly come in when emergency arises. We also we build the capacity of community workers, like peer supporters. Like, for example, the Red Plus program works with peer support. We also work with the activists in other programs, child protection committees, and we for all this cadre of a resource, we make sure that we train them and are able to provide the psychosocial first aid and make a referral of acute case when it's necessary. So they can screen, they can also make references to specialized support when it's the case. In addition to that, we also, as a reps, we continue to sustain our membership in the response clusters. So when there are classes in Mozambique, different clusters that respond to emergencies, like child protection, health clusters, and other GBV clusters. So we, as a reps, we are part of all different classes, so to make sure that the mental health and psychosocial support is integrated within the response to the emergency. Why integrating the mental health and psychosocial support it's important? I would maybe I would refer myself for going much more deep in terms of the consequence or the impact on mental health and psychosocial support of those who are affected by natural disasters or climate issues. But just to mention a few, we found that people they experience situation like of extreme stress, trauma, insecurity, and other challenges which are related to the climate issues. And some of the reason why integrating psychosocial support is important is because you'll find that, for example, for people affected by HIV, they might, for example, have difficulty to take a decision on whether to continue with the treatment in a new health facility after being displaced from the original areas of residence. So moving from one place to another place, it always represents a challenge that requires one to make adaptations to the new environment, to the new system and the new people with whom the person has to interact with in order to continue with the treatment. And sometimes taking decision just for that can be extremely challenging or difficult. So you find that there are also circumstances where people they have a fear of death or deterioration of their health conditions after having been forced to interrupt the treatment, and that can also lead to increase in terms of viral load, or even to decrease their health well-being. There are issues that I've mentioned before of stigma discrimination. So many adolescents, for example, and young people face social isolation, which also is exacerbated the emotional impact of caused by emergency. So stigma and discrimination can also be one of the reasons why mental health and psychosocial support is needed, because it has the power of creating an enabling environment for those people who seek service in new displaced areas. There are also lots of family support.
Sorry, Julio, sorry to cut you off. We do have 10 minutes, so do you mind just wrapping up?
Actually, that was my last item, that there are also issues of loss of family support in many crises. Children lose their carers, increasing risk of depression, anxiety, and negligence. So those are some of the issues why integrating mental health psychosocial support is quite important. Thank you.
Thank you so much. Definitely, the impact of mental health in these settings is often under, we really don't give it as much attention as it deserves. So thank you so much for bringing that perspective to the panel. I'm just going to have a final question for Ishmael, but I'm just going to ask the panelists to also look in the Q&A to look through the questions and answer them as well, because we're running out of time. So next we will be having the Global Fund remarks. So just look into the Q&A section. So Ishmael, to wrap us up, can you tell us why is it essential to involve and meaningfully engage young people in the communities most impacted in climate responses, as well as policy and decision-making spaces?
Thank you so much, Ajwa. So it's actually important because already young people are the primary stakeholders in as far as we are talking about community engagement or the services that are actually disrupted because of climate change, whatsoever that actually affect us as young people. So we are the primary stakeholders to make sure that we are engaged and we are also on the tables where the decisions are actually being made. So it's important because one, young people already have platforms and already have innovative ideas which can actually help to mitigate some of these challenges that are being faced in the communities in access to healthy related services. And of course, we are also part of the committees or decision-making platforms in the communities where the decisions are already made. And if we are meaningfully engaged, it means we can contribute towards that and make sure that some of these challenges are actually brought into attention of young people and the communities. And talking about the policies, if the policies are actually developed, we are to use those policies. We are to make sure that young people are actually adapting to the policies and guidelines that actually helps to mitigate the challenges. So if we are not meaningfully involved, then it means the policies that are going to be developed are not going to work for young people. But if we are part of those policy making and decision making, it means we are also going to bring in our views as young people as per what works for young people and what can young people contribute towards ending some of these challenges. And once all those views are taken into consideration and they are put into the policies that are to be used by the young people themselves, it means we are creating something, we are developing something that is feasible and also doable by young people themselves. So we just have to be there. We just have to be on the table. We just have to be in the platforms where all these things are actually happening to make sure that we also quickly adapt to some of these issues that young people should be there. Thank you.
Thank you, Ishmael. Really important last words. So now I'm going to hand over to Global Fund. We have Sunmi Choi, who's joining us. Sunmi is the Senior Advisor, Climate Change and Environment with Global Fund, with over 20 years of global experience, including more than 15 years at the UN, United Nations. Sunmi currently serves as a senior advisor, as I mentioned. Since joining in 2023, she has acted as the organization's focal point, leading the strategic approach and policy development regarding climate and environmental matters. Her previous leadership roles include serving as UNICEF's first climate and environment advisor in East Asia and Pacific, and managing climate resilience and poverty environment initiatives at UNEP and UNDP across Africa and Asia Pacific. Sunmi, you are welcome.
Great, thanks so much. Very glad to be part of this discussion and really grateful for all your rich perspectives and input as I'm really learning about all your amazing work, and you're really on the front line dealing with the immediate impacts of climate change on HIV program and key populations. Today, I think we have like a few minutes left in this meeting, so let me try to just share a few quick words also from the Global Fund side, as we are also gearing towards the next grant cycle. Maybe before we go into the Global Fund, the programmatic approach and framework on climate change, I think these discussions today were really a testimony of the climate impacts on the ground, which is not at all theoretical, really acute shocks and stresses that our vulnerable communities are already experiencing. But I do think when we talk about climate change and its impacts, it's very important for us also to not talk only about acute shocks, in particular extreme weather events. Of course, this is the major manifestation of how climate change is affecting us, the increasing intensity and frequency and the geographic distribution of extreme weather events such as cyclones and floods. But also importantly, and it is very difficult also to quantify, is the slow onset changes. We call it slow onset events, which basically mean much more gradual and much less visible changes that are actually producing persistent stress that actually reshape our natural ecosystems, but also livelihoods and also infectious disease patterns over time. And I think that's an area that when we talk about climate change, it's also beyond just about immediate disaster risk, disaster response and humanitarian work, but a little also more complex and cascading impacts of other invisible slow onset changes that are also huge impacts on HIV affected communities. And then the other important point I want to also emphasize as we discuss about climate and HIV in general, for us from the climate community to better support HIV community to understand and to manage climate change risks more effectively, I think the obviously very important starting point is really data and evidence. We're not only talking about scientific literature, but also really lived experience. We have, our colleagues here, community representatives and policymakers. You have all the lived experiences, and we need to consolidate this experience and information in a much more, comparable and transparent and quantifiable manner. So the impacts and the links between HIV and climate are much more clearly communicated and understood. And only then we can really also come up with a much more scalable and proven solutions to address the problem. But that's maybe just some of the key points from the Global Fund side. As you can see, even just the fact that I am at the Global Fund. I am the first senior advisor on climate change and environmental issues at the Global Fund. So that already, I think, it kind of shows as a signal that the climate change agenda is a very important integral part of our programmatic response. Basically, Global Fund, current cycle, over 70% of our investments in the 7th grant cycle right now are going to the 50 most climate vulnerable countries. So, when our vast majority of our investments are in some of the most climate vulnerable countries, the efficiency and the impact of our investments really, it will depend on our ability to actually effectively manage the different complex impacts of climate change on HIV, TB, malaria, and wider health systems. So the climate impacts and the responses to these impacts from the Global Fund side is not a separate new agenda. It's really an integral part of our mission. And I think in terms of the data, from our side, the kind of data that we have available, which really helps us strengthen the programmatic response to climate impacts on HIV and other programs. It's like, as an example, the Cyclone Freddy, which officially recorded as the longest ever recorded tropical cyclone ever. Cyclone Freddy actually, in the aftermath of Cyclone Freddy, we could actually gather some data from UNICEF and others that HIV patients that were displaced, there was a massive displacement, and in addition to destruction of health facilities and health access, HIV patients displaced by Cyclone Freddy, for instance, in Malawi, we see that up to 30% long-term treatment default rates. There's a clear data that has direct impact of climate-induced displacements on HIV treatment and its health outcomes. Yeah, and in addition, I think the other impact that we're also looking at in a more complex manner is about the impacts related to food and malnutrition, food and nutrition security, and how they're actually also adding existing vulnerabilities to key vulnerable populations that we're focusing on from Global Fund on, in particular, HIV/TB programs. So these are some of the key issues that we're really looking at, and I think in overall we're really looking at our programmatic response and investment priorities on addressing impacts of climate change on HIV and TB and other health programs is first and foremost, of course, immediately supporting countries to better manage climate-related disasters, to minimize disruption and minimize the decreased access to and quality of prevention and treatment services. Second one is about climate-induced displacement. As I mentioned, climate-induced displacement is observed in so many countries and has a profound impacts and immediate acute stress about disruption of the service continuity, but also about increased risk of HIV transmission, as some of our partners here have already elaborated, and also poor living conditions and all that. The third area we're looking at is the climate-driven food insecurity, also nutrition insecurity, and also loss of livelihoods, poverty in general. So basically, climate-triggered food insecurity and nutrition insecurity, together with livelihood loss and poverty, definitely have a very complex cascading impacts on HIV and populations that we're focusing on through our HIV and TB programs. And I think these are multiple pathways that we are observing, and we really are urging our partners, including partners here in our partnership on the HIV fight, to really have the sense of urgency and prioritizing measures to address this climate impact, and also really looking at some proven solutions. Let's try to look at, based on your lived experience, proven solutions with the potential for scalability and also more systemic impact. And obviously important to point out is importance to partner with other climate change stakeholders and aligning our HIV and health programs with the national climate change plans, national adaptation plans, and also finally a huge focus we have to, even more important, is leveraging locally led, really community-based approaches. And we heard from our partners here from, I think it was Uganda and Malawi, importance of engaging with community actors and also deploying at scale more flexible service delivery models, community-based service delivery models, also including mobile clinics and community delivery points and all that can really be much more flexible and provide more anticipatory and proactive risk reduction approaches. So overall, we really hope that we're available to further discuss with you and learn also from your lived experience how best to integrate already observed impacts of climate change on HIV program, but through a very integrated approach and health systems approach. That's it from myself. Thank you. Thanks for this opportunity.
Thank you so much for joining us. And it's actually really, really encouraging to hear, the Global Fund kind of share their commitment to the climate and health nexus. And it's also really encouraging to hear that there's an equitable distribution of investments to the countries that are most impacted and when it comes to climate vulnerability. So thank you very much for being here. And we hope that we can take these conversations up in the new year as you've offered. So colleagues, thank you so much for your attention. I know it's close to the end of year for most of you. And so really appreciate your engagement. Looking at the Q&As, it seems like most of the questions have been answered. So thank you, panelists and presenters for that. I believe there's one more question, but in the interest of time, because we actually are 5 minutes over, I'm just going to ask our presenters to take a quick look at that one and then respond. And then I have the pleasure of wrapping us up. So the first thing I do want to say is that the recordings for this webinar, as well as many others, is available on the SSLN website. And my team will drop that in the chat if you're not familiar with it. SSLN also has a YouTube channel, so please head over to that as well and access a lot of the resources and past recordings there as well. So again, it was my absolute pleasure to chair this very necessary meeting. I think we cannot understate the effect of climate change on health and definitely on HIV. And I hope that this meeting has given you, has convinced you that there is a strong relation between climate and HIV. There are challenges related to it, but then there are solutions. So let's use this this community that we have created here to keep discussing, keep wrestling with these hard realities, and keep co-solutioning for the benefit of the communities and the people who most benefit from it. So again, thank you for listening. Again, my name is 𝗂𝗃𝗏, principal here at Genesis, and I look forward to catching you at the next one. Thank you and have a blessed rest of your day.